In our last lecture, we talked about Alzheimer's type dementia and the pathophysiology involved there. And today we're going to go over all of the non-Alzheimer's dementia syndromes. So multi-infarct dementia is probably the second most common cause of dementia. It's either the second or third. And it has a different presentation than Alzheimer's disease because patients get worse with each stroke. And so, they have a significant decline after the stroke, then they're steady for a while, and then when they have another stroke, they take another drop off, in comparison to Alzheimer's disease where it's just a steady decline. So most often these are cortical strokes. So the patient has an MCA stroke, and then an ACA stroke, or a PCA stroke. So involvement of the cortex would be most common. Okay, the more you have, the more likely you are to have some memory impairment. And so in addition to just having memory loss, of course, these patients will have focal findings. And so that's a key feature of multi-infarct dementia. So they're patients that are cognitively impaired, but they have a hemiplegia. They have a homonymous hemianopsia. They have an aphasia. They have focal findings from their strokes. So that is very much in distinction from Alzheimer's dementia. So remember I mentioned those patients can have some aphasia, some paraphasic errors, things like that, but it's in proportion to all of the other cognitive deficits. Patients that have multi-infarct dementia will have deficits that are out of proportion to the memory loss. So if it happened to involve the left hemisphere, Wernicke's-Broca's area, they'll have an expressive or receptive aphasia that will be out of proportion to the other deficits. Now, frequently at autopsy, when maybe we think someone has multi-infarct dementia, we'll find out that they also have pathology that's consistent with Alzheimer's dementia. And remember that all of the vascular risk factors are risk factors for developing Alzheimer's disease. And so that's why oftentimes we get this kind of what we call a mixed dementia, where it's a combination of Alzheimer's and multi-infarct dementia. So less likely, but this can occur, is where someone has lots of subcortical strokes and can have dementia from that. That has a somewhat different presentation, however, than cortical strokes. So these patients also have focal findings. They usually have pseudobulbar palsy. Okay, remember the pathway that is you want to associate with pseudobulbar palsy. It's the cortical bulbar tract, the pathway that connects the cortex with the bulb, which is the brainstem. And so you disconnect, in particular, the cortex from the medulla, where talking and swallowing occurs. And so patients with lots of subcortical strokes frequently have pseudobulbar palsy with significant dysarthria, dysphagia, emotional incontinence, everything that we've talked about before with pseudobulbar palsy. But lots of subcortical strokes tends to cause a dementia that looks a lot different than Alzheimer's. It's a withdrawn, depressed, demented patient. And we even call that a subcortical dementia. Remember, your Alzheimer's patients tend to be, telling jokes, oftentimes a little bit more on the outgoing side. All right, so down here we have a patient with lots of subcortical strokes. Okay, and so this is, we'd anticipate this patient would have cognitive impairment from just the burden of disease here. And it's not hard to imagine you're going to pick off the cortical bulbar tract here on both sides with so many lesions. And here are just examples of a PCA stroke, a bilateral ACA stroke, and an MCA stroke. And so again, the more of these you have, there's going to be some cognitive impairment. And so we have now been through all the different things, common things, that will cause pseudobulbar palsy. So maybe it's a good time to put it all together. So in this lecture, multi-infarct dementia with particularly lots of subcortical strokes, PSP and multisystem atrophy. So remember in our differential of Parkinson's, but both of these conditions commonly result in pseudobulbar palsy. ALS, of course, which is a motor neuron disease, right? So you lose the neurons that contribute to the cortical bulbar tract, and in multiple sclerosis where we have demyelination of central nervous system pathways like the cortical bulbar tract. Okay, so there's a good differential for pseudobulbar palsy. Now, right up there with multi-infarct dementia, I think probably the third most common cause, in some studies maybe the second most common cause, is diffuse Lewy body dementia. And Robin Williams' death 5 years ago sort of highlighted this condition. So I just took the headline here from CNN, where a neurologist said diffuse Lewy body is often misdiagnosed as Parkinson's disease, like Robin's case, sometimes as Alzheimer's disease or another disorder, depending on what symptoms predominate, if they are cognitive or movement related. And so we kind of think of diffuse Lewy body as having overlapping features of Parkinson's and Alzheimer's dementia. So this is a relatively recently described condition in the mid-1990s, where it was found that these Lewy bodies that we talked about in Parkinson's disease, that you found in the substantia nigra, that some patients with dementia have these scattered throughout the brain. So they're not just in the midbrain, but we find them all the way up to the cortex. And so again, this is a relatively common cause of dementia. And so how do we tell the difference, first of all, with Parkinson's disease? Well, the rule of thumb is that if a patient looks Parkinsonian and the dementia begins more than a year after the onset of those Parkinsonian features, it's probably Parkinson's disease. But if the dementia begins at or within a year of the onset of Parkinsonism, then it's more likely diffuse Lewy body disease. All right, so diffuse Lewy body has several key features. One is that there's often a dramatically fluctuating cognition. And a patient I just saw recently, his wife said, some days he's pretty good, but then he'll just have a period of time where he just shuts down and can hardly function and he doesn't talk. And so they can have kind of these almost like spells where they are not very responsive and maybe very confused during those episodes, not very alert. That's distinctive. The second, and I've found this to be probably the most helpful thing historically that points towards diffuse Lewy body, is these patients have profound hallucinations, usually visual. So remember when we talked about hallucinations related to dopamine agonists or dopamine, which you get for Parkinson's disease. And so they're like that. They're very profound. I mean, they're seeing people. They're seeing often violent images. And again, because they have dementia at an early stage, they're less likely to be able to recognize that these things are not real because it kind of mixes in with their dementia syndrome. But unlike Parkinson's disease, the hallucinations in diffuse Lewy body are an organic part of the disease. It's not caused by medications. It's just part of the condition. Right? So that's very distinctive. They have motor features of Parkinsonism. They tend to have less tremor. There are some subtle differences between diffuse Lewy body Parkinsonism and what you see in Parkinson's disease. And REM behavior disorder, which remember you see with any synucleinopathy, like Parkinson's disease, like multisystem atrophy, rates are even higher of this in diffuse Lewy body. In some studies, way above 95%. So remember that acting out of dreams at nighttime, which can be quite violent. So I mentioned that Parkinsonism is a little less. They tend to have a little less tremor. I mentioned in Parkinson's disease that late in the disease, patients can have orthostasis. This tends to be a more prominent early feature in diffuse Lewy body. These patients are hypersensitive to any dopamine blocking medications. Even a single dose of an antiemetic or a neuroleptic can have a profound impact on these patients. Sometimes that's helpful, historically. When patient was given something for nausea and they had a dramatic reaction to it. They couldn't move for a period of time, something like that. That's something we'd see in diffuse Lewy body disease. And 10% of patients may have something known as Capgras syndrome, which I've seen several times. And this is very interesting, kind of curious condition where patients with diffuse Lewy body develop this sort of a fixed idea, usually that their spouse has been inhabited by someone else. It's not really them. It looks like them, but it's not really them. And that's obviously very distressing for family members or for the spouse. So the pathology of diffuse Lewy body overlaps with Alzheimer's and Parkinson's. So we have, as I mentioned, Lewy bodies throughout the brain. Okay, similar to the typical Lewy bodies that we see in Parkinson's disease, but it also does affect the substantia nigra, so that's why there are Parkinsonian features. But we also have some features of Alzheimer's dementia. So we have a loss of those acetylcholine-producing neurons, like in the nucleus Meynert and elsewhere, and we get atrophy, and you can even see some neurofibrillary tangles, although they are less common than in Alzheimer's dementia. All right, so here is kind of a bird's eye view of the substantia nigra. We see these pigmented neurons, but if we focus down here on one, well, we can see there's a Lewy body. And so, as I mentioned in Alzheimer's, there are some things you just need to be able to recognize for your upcoming final and also for step 1. So you need to recognize a neurofibrillary tangle, amyloid plaques, Lewy bodies. These would be just some of the kind of distinctive things you need to be able to recognize. Treatment of diffuse Lewy body is difficult. So they have some Parkinsonism, so maybe you'd like to give them dopaminergic medications, but what's going to happen? Well, they already have hallucinations frequently, so you're going to worsen hallucinations by giving those medications. So that makes it tricky, very difficult. You don't want to give them, for the hallucinations, typical neuroleptics that block dopamine, right? Because that's going to worsen their Parkinsonism. So there are a lot of challenges. So we'll typically use atypical neuroleptics like quetiapine, which I mentioned during the Parkinson's lecture. Neurologists like quetiapine just because it doesn't have much effect on dopamine pathways, so it doesn't really worsen Parkinsonism. At least rarely does that happen. And in our lecture on Alzheimer's, I mentioned the anticholinesterase inhibitors that act centrally, and so I sort of highlighted donepezil, but I told you another one you need to know about is rivastigmine. And I mentioned that just because rivastigmine is more studied for diffuse Lewy body. So we'll more often use rivastigmine to try to improve the memory function, and this can also actually be helpful for some of the behavioral issues that go along with diffuse Lewy body. All right, so I won't say much about this because we talked about dementia during the Parkinson's lecture, but remember 30%, roughly, maybe up to 40% of patients with Parkinson's have dementia, but it's a late feature of the disease. So I said more than a year, it's usually longer than that. So it's something that we would see later in patients with Parkinson's. So overall, they have about a 4 times higher risk of dementia if you have Parkinson's. And it's a challenge then to treat. You want to give dopamine medications, but if you cause hallucinations in someone with dementia, it's very troubling for the patient and family. Huntington's disease also we've covered, so I just want to kind of have you add that to your differential in someone with dementia. Huntington's is usually not much of a mystery because they've got the triad, right? Remember, it starts usually with a behavioral problem, merges into a dementia, they've got chorea, and you've got, because it's autosomal dominant, a family history, all right? So it can be difficult with some of these others. They overlap so much with Alzheimer's. Huntington's is usually not difficult. So remember, later on, they go from chorea to more of a Parkinsonism, and we look on MRI for atrophy, especially of the caudate, and then this is one of our trinucleotide repeat conditions. So we've been over that in a lot of detail. So here's a head CT of someone with Huntington's. I've shown you before. So we see lots of atrophy. Look at the big Sylvian fissure here. Sulci are much larger than they should be. Big temporal horns of the lateral ventricles, and no caudate nucleus here. So that's why the lateral ventricles here appear especially large. Remember, the pineal gland calcifies with age. So here's the calcified pineal. So we know where we are in this head CT. We're just above, right here, the dorsum of the midbrain. Now, our second to the last lecture in this course will be about neurologic complications of HIV. So we'll sort of save this topic for then, but as a late manifestation in patients with AIDS, they can have this HIV-associated dementia complex. And so sort of like the patients that have lots of subcortical strokes, these patients also tend to have a withdrawn, depressed appearing dementia. And so I will tell you, when we get to this lecture, that when you have someone who's HIV positive that's having memory issues, this is a diagnosis of exclusion, because there are so many infectious, treatable things that can cause memory loss. We do a big workup, typically, MRI, lumbar puncture, the whole thing, to try to find something that's treatable, fixable, because we really can't intervene if it's this HIV-associated dementia complex. Okay, so we do need to spend some time talking about JAKOB-CREUTZFELDT disease. And I sort of put in here two things. People will often call it CJD, or JAKOB-CREUTZFELDT disease, or Jakob's disease. And just for trivia, but because I found this interesting when I learned this several years ago, that back in the 1920s there was a Dr. Jakob and a Dr. Creutzfeldt, and they both described these patients who had sort of a rapidly progressive dementia syndrome. And so that's where we get the name, Jakob-Creutzfeldt or Creutzfeldt-Jakob. But it turns out when people went back and they looked at the brains of the individuals here that were described, only Dr. Jakob's patients had prions. Okay, and so that's why for a while it was known as Jakob's disease. Now in the 1960s there was a researcher at NIH, and his initials just happened to be CJD. And from information we have, it appears that he just thought it would be cool if this condition were called, after his initials. So he started to call it Creutzfeldt-Jakob disease, and so that's kind of how we get the reintroduction of that term. But many neurologists I know are calling it Jakob's disease, sort of in recognition of the history of this. So this is a rare condition, literally about 1 in a million. Although I have personally seen 3 cases in the last 2 years at the VA hospital. So it seems like every once in a while we just kind of a little bit of a cluster. And Jakob's disease starts a little bit younger, kind of a mean age of 61, but between 50 and 70 would be kind of a typical age. And these patients have kind of a unique presentation. Definitely what stands out the most is a rapidly progressive dementia. What do I mean by that? Well, most patients die within 6 months of the onset of symptoms. All right, so that's much different than Alzheimer's, diffuse Lewy body, most all the other conditions that we've talked about. They also have these myoclonic jerks. Now we'll talk more about myoclonus in the epilepsy lecture. There is epileptic myoclonus and non-epileptic myoclonus. This is not epileptic. But we've all experienced some myoclonic jerks. When you're falling asleep at nighttime and you occasionally had it where your whole body will just jump, jerk. That's a myoclonic jerk. And these patients can have these, they're quite profound. They're what we call stimulus induced. So if you go into the patient and you make a loud noise, you clap your hands or bang on the bed rail or something like that, that will often cause their whole body to jerk. And so a stimulus-induced myoclonus is kind of a distinctive feature of Jakob-Creutzfeldt disease. And cerebellar pathways are usually affected in this condition, so they have ataxia. And you'll see a lot of clumsiness when they try to eat or use their hands for something. So there can be a lot of other features. So we'll talk about these prions, but if it tends to involve other areas of the brain, they can have aphasia or visual loss. And so I would say of all the things here, what would be the most consistent feature? It would be the rapidly progressive dementia. All right, so this is a prion disease. A prion is a proteinaceous infectious particle. So it's not a virus or something like that. The infectious agent is made only of protein. And Dr. Deich has already shown you the spongy degeneration of the brain that is characteristic. So everyone has prions in their brain. These are in a native, normal state. It appears, not a lot is known about their function, but they appear to be important for transmembrane transport and signaling. Okay, what happens is in the abnormal state, I'll show you a picture of how they fold abnormally and cause death and destruction of neurons. So here's a really nice drawing that Samantha, a fourth-year medical student, completed for me just a week or two ago. And so here's a neuron, and so we see in green here some normal prions. And they're doing something for transmembrane function, normal. And so here's a normal state here of a prion protein. Okay, notice we don't see much of this red here, which is this beta pleated sheet here in the normal prion. Okay, but when we get an abnormal version of this prion, notice now all the red, this beta pleated sheet here, what happens is these abnormal prions combine with the normal prions and it all transitions into the abnormal form of the prion proteins. Okay, and these abnormal prion proteins can't be broken down or destroyed by the neuron, and so they eventually kill the neuron and spread on to the next neuron, and it propagates rapidly. Okay, so here is a normal prion protein. So this prion protein cellular. Okay, and notice we don't have much of this blue here, this beta pleated sheet. Here is an abnormal prion, which is called prion protein scrapie, and this is after a prion disease that affects sheep. Okay, and so it's felt that these combine here into an intermediate state, which is called protein X. This has not yet been identified, but this is the hypothesis that they combine in an intermediate state then to produce two of the abnormal prion proteins. So we went from, one conversion of one into two abnormal prion proteins, and then to 4 and 8 and 16 and 32, and so this just happens exponentially and spreads throughout the brain very rapidly. And so we have a patient with rapidly progressive dementia. Now there's a big differential for this. And so in the encephalopathy lecture, I'm going to tell you about autoimmune encephalitis, and we'll go through some other things, non-dementia syndromes that can progress kind of rapidly. And so we really need to do a big workup to sort this out. So first of all, we can do an EEG, which we will talk about in the epilepsy lecture, but you get these periodic sharp wave complexes, these bursts of abnormal electrical activity in the brain. We do a lumbar puncture in these patients. Again, we're going to do the brain scan first, right? We want to make sure we're not dealing with a mass lesion. But we can check for a couple of things on the cerebral spinal fluid. One is the 14-3-3 protein. Okay, and this is, it's a normal protein, but it spikes anytime there's damage to the nervous system. So for example, if someone has a big demyelinating episode for multiple sclerosis, the 14-3-3 protein spikes. And so this is not specific for JAKOB-CREUTZFELDT disease. It's pretty sensitive. A better test, which is more recent, is the RT-QUIC test. And as I understand it, this test, what happens is we get conversion. If there is an abnormal form of the prion protein scrapie, it gets converted to amyloid. And so this test is more than 90% sensitive, and it's highly specific, more than 95% specific. So this is a really helpful confirmative test here for JAKOB-CREUTZFELDT disease. All right, we do an MRI scan of the brain, and so we can see atrophy, frequently some signal changes. Notice here in the caudate and in the putamen, we've got some bright spots showing up there. And even more classically, we get what's known as cortical ribboning. Just notice how the cortex here just gets outlined, enhanced here in patients with JAKOB-CREUTZFELDT disease. So that's quite distinctive. So most cases, all the cases I've ever seen of JAKOB-CREUTZFELDT disease were sporadic forms. All right, so we don't know why the individual gets it. They're sporadic cases. Very rare there is a familial form of JAKOB-CREUTZFELDT disease. These are often autosomal dominant, and so here we have a mutation of the prion gene. All right, iatrogenic. There have been no more than 300 cases ever reported of iatrogenic JAKOB-CREUTZFELDT disease. So this can happen with contaminated human brain products, so growth hormone, maybe from a cadaver or a dural graft, rarely corneal transplants, or intravenous immunoglobulin that we've talked about as a treatment for Guillain-Barré and other conditions. But there hasn't been a reported case of that in many, many years. Okay, so there are, again, about 300 cases of iatrogenic. Variant JAKOB-CREUTZFELDT disease, I think no more than 250 cases of this have been reported. And so this is bovine to human transmission. This is what everyone talks about and is concerned about, right, with regards to meat consumption. And so the presentation of variant JAKOB-CREUTZFELDT disease is a little different. It tends to be younger individuals under the age of 30. They have a different clinical presentation. They still have a rapidly progressive dementia, but there are some other features that I just won't go into because it's so rare. There has not been a single case of this in North America. So these cases have all been in England and France and some other European countries. Patients with variant Creutzfeldt-Jakob disease have what's called the pulvinar sign here. All right, so remember the pulvinar is a nucleus of the thalamus, and so this kind of lights up right here. This is sometimes called the hockey stick sign because it a little bit, looks like a hockey stick right there. So that's what we might see on the MRI in someone with variant Creutzfeldt-Jakob disease. Now, there was a study, not to be an alarmist here, but several years ago that looked at the British population, and they found that 1 in 2,000 individuals had an abnormal prion protein scrapie in the lymphatic system. And so now these are not individuals that are symptomatic, obviously, but why is this a little bit concerning? Well, if we look at another form of prion disease, which is Kuru. Kuru was seen, I think, in the 1950s when it was still done in New Guinea to consume the brain of a person who'd passed away. And so I think the idea is, you consume the brain of a loved one, they become a part of you. And so these individuals would develop features of JAKOB-CREUTZFELDT disease. Same thing, rapidly progressive dementia and death and so on. But the incubation period was decades from ingesting the brain and to getting clinical symptoms. So this is perhaps a bit alarming that, again, from meat consumption of cows that have the abnormal prion protein, that such a high percentage of the British population has that in their lymphatic system. So again, it isn't known. What do we do with that information? It just seems a bit concerning. Now, frontotemporal dementia, I would say, is the one that maybe along with diffuse Lewy body or multi-infarct dementia that will sometimes confuse with Alzheimer's disease. One feature is that these tend to be younger individuals. And so, as a general rule, under the age of 65, the incidence of frontotemporal dementia is the same as the incidence of Alzheimer's. So if we have a younger individual presenting with some of the things I'm going to talk about here, including dementia, we need to bring frontotemporal dementia to the forefront. The older term for this is Pick's disease, but neurologists prefer now just to call it frontotemporal dementia, which really describes what it is. So we have degeneration, as the name indicates, in the frontal lobes and the temporal lobes. But it's not primary motor, primary sensory cortex. So they present with some cognitive, behavioral, language changes, as I'll discuss, but they don't present with a progressive hemiplegia or hemisensory loss, that kind of thing. So overlaps with Alzheimer's dementia, but it tends to present with early behavioral personality changes. Remember, that's a rather late feature in Alzheimer's. Okay, these patients are socially normal early on, whereas in frontotemporal dementia, that's an early feature. Now, if the involvement in frontotemporal dementia is on the language-dominant hemisphere and involves Wernicke's or Broca's area, then these patients have a progressive receptive, it tends to be more likely Wernicke's, aphasia. All right, and so they're not understanding language well, but it seems to be much more focused on language than in the, again, what we see in Alzheimer's, where the language deficits are in proportion. Here it would be out of proportion. So a little more than half of frontotemporal dementia is this behavioral variant. Okay, and so remember the orbital frontal cortex we've talked about before, that I mentioned if you have a lesion there, we get a disinhibited patient. And that's exactly what we see in frontotemporal dementia. And so these patients are frequently noted by family members to be making inappropriate comments, frequently of a sexual nature. A lot of the men that I've seen with this at the VA, the spouse will say, he's just always been the nicest individual, and now he sees another woman and he's making comments about her body or something like that. And I have several times had the experience where, I'm walking the patient back to the waiting room and, he'll make an inappropriate comment about the nurse or something like that. And so they just kind of lose that filter. And so making inappropriate comments, often a little bit, they're on the edgy side. And so I had a patient with frontotemporal dementia where I was checking his reflexes, and he wasn't looking very nicely at me, and he said, "I'd like to hit you with that reflex hammer." A little bit aggressive. I heard another neurologist tell the same story. So that kind of interaction with a patient, we might see, a little more aggressive, edgy patient. Remember the frontal poles, the very tip of the frontal lobe, that this is involved in metacognition, and that degeneration or lesion here results in a loss of empathy. That's another typical feature. One of my patients with frontotemporal dementia, kind of a clue to me that that's what was going on, is his spouse said, he's always just been a very, very kind, concerned about me, but she developed breast cancer and he seemed unconcerned. Okay, so loss of empathy is distinctive. They also have a hyperorality, frequently for sweets. Frequently they'll develop a focus on one type of sweet that they will consume, and often will have some weight gain, and family may want to lock away, that sweet to, just kind of put some distance. Compulsive behaviors are also common. So patients may develop this habit of checking the locks on the doors 20 times before they go to bed. I have a patient that developed, he'd always had a stamp collection, but now that's all he can do, is just focus on his stamp collection. Or some other hobby. I heard a story of a patient who had this metal detector, and just all he can do is every day is go to the beach or somewhere and look for objects with his metal detector. So some sort of a compulsive behavior will often develop. And no more than 20% of patients may have a motor neuron disease. And I'm including this next slide here from our lecture on the genetics of ALS, just to remind you that the most common mutation that we see in ALS is of the C9ORF72, that these account for 40% of familial ALS, and this is the mutation in about 5 to 8% of sporadic ALS. And so this is the genetic mutation that we associate with frontotemporal dementia. So 10% of ALS patients have frontotemporal dementia. 20% of patients with frontotemporal dementia have a motor neuron disease. So if you have a patient with, presenting with behavioral changes consistent with frontotemporal dementia and they're getting weak, well, most likely they have the associated motor neuron disease. All right, so notice the focal frontal atrophy compared to, relative preservation of the occipital and parietal lobe here, and we can also see some atrophy of the temporal lobe. So we can see that on MRI as well. Dr. Deich has gone over the neuropathologic findings, which I won't repeat. It does overlap a lot with Alzheimer's. And so now more and more these neurodegenerative conditions are being described by the abnormal protein. And so now we've been over all of these conditions here. So remember the 3 synucleinopathies are Parkinson's disease, multisystem atrophy, dementia with Lewy bodies, and here we have our tauopathies, which is PSP, Alzheimer's disease, and frontotemporal dementia. Okay, so you need to be able to separate and distinguish between these just kind of on the abnormal protein. Now, Korsakoff syndrome is due to thiamine deficiency, and frequently we'll see this in relationship to chronic alcoholism. Last year we talked about Wernicke's encephalopathy, but this is so important I'm going to just repeat this. So remember, Wernicke's encephalopathy is a triad of ophthalmoplegia, which remember just means an eye movement abnormality. Typically it's a bilateral 6-nerve palsy, but it can do just about anything. So we've got a profound eye movement problem. These patients are confused, and if it's untreated, can even progress to coma, and they have a gait ataxia. Okay, so how does Wernicke's present? Well, remember, this is usually patients that come into the hospital normal. They're in the hospital for something, right? Knee surgery or something else, but they're given IV glucose. And if you give IV glucose to someone who has a baseline thiamine deficiency, it acutely brings out the triad here of Wernicke's encephalopathy. Okay, and so that's usually the story. Now, Korsakoff syndrome is sort of the dementia syndrome that can come out of Wernicke's encephalopathy. And so really the longer you go without treating someone who has Wernicke's encephalopathy, the more likely they're going to develop this Korsakoff syndrome. And this is really a unique condition. Everything we've talked about really with memory loss and dementia, it tends to be more anterograde. Okay, you can't learn new information. But in Korsakoff syndrome, these patients have retrograde memory loss. They have these patches of memory loss for things that happened many, many years ago. And so that's rather distinctive, anterograde and retrograde memory loss. So their level of alertness and attentiveness is relatively preserved. So sort of like an Alzheimer's patient, they're socially appropriate. They also tend to have little insight that they have a deficit, just like someone with Alzheimer's. But because of those patches of memory loss they have for things that happened decades ago, what happens is they just naturally fill in the gaps of those patches of memory from a long time ago. And that's called confabulation, which describes false or invented memories. They're not doing this maliciously, okay? But they have a large gap of whatever happened 30 years ago, and the brain will just kind of fill in with some invented memories. And so these patients are fascinating to talk to. And we had one at the VA just within the last couple of months. And, every day would go in and talk with the patient. And I would ask the patient every morning, do I know you from somewhere? And at least on 2 of the days I did that, he had a different story. Okay, once he remembered me from when he grew up in Minnesota. and then another time it was a different story. So again, there's kind of these invented memories, or confabulation is a distinctive feature. Now, remember the Papes circuit, which does involve here the mammillary bodies right here. And if we look here on an MRI, these are, remember here's the midbrain, and so the mammillary bodies are just ventral to that. And so if we do an MRI scan in someone with Wernicke's encephalopathy, we will see signal changes here in the mammillary bodies. There can be some other areas that can be abnormal, like here around the cerebral aqueduct and other places. But you want to associate changes in the mammillary body with Wernicke's encephalopathy. Now, normal pressure hydrocephalus. This is such a frequent board question, but I really want you to hear me on this in terms of what an overdiagnosed condition this is clinically. So it's always on step 1, I think. It's always going to be on national board exams. But that's a very frustrating thing for neurologists because we think this is an overdiagnosed condition. So true NPH, and there is a true NPH, it does exist, but it's exceptionally rare, and a lot of that has to do with perhaps the most non-specific triad we could come up with. And so classically in NPH, it starts with a gait problem. It's called a gait apraxia. So remember what it is, an apraxia. This is a problem with motor programs. In this case, it's the motor program for walking. All right? It isn't that the legs are weak, or we don't really have an ataxia, problem with the vermis of the cerebellum, but the motor program for walking is distorted. And so these patients have a normal leg exam in bed, but when they get up to walk, it's like they don't know how to use their legs. And especially with gait initiation, getting the feet going is difficult. And then they have dementia and urinary incontinence. Now, just think of any patient you're ever going to see with Alzheimer's disease. They're demented. How common is urinary incontinence in the elderly? Very common. How common are balance problems in the elderly? Very common. So we have just an extremely nonspecific triad, and it actually turns out, and I didn't highlight this in the handout, because on board questions they'll give you this triad and you need to choose normal pressure hydrocephalus. But not all patients with NPH, in fact most, don't even have the full triad. And there can be some Parkinsonian features as well. Their gait can appear a little shuffled, they can have a little rigidity, and so we can have some overlapping features there. So what happens? Well, we have a dilation of the ventricular system, in particular the lateral ventricles here. And so remember, from the paracentral lobule, which is motor and sensory for the leg and bladder, that these fibers are going to loop around the lateral ventricles, okay, on their way down to the innervate areas of the spinal cord for your leg and bladder. And so if we have a dilation of the lateral ventricles, it's going to disrupt these pathways that are going down to the leg and bladder. So that's the idea for why the walking and bladder function is affected. And of course, cognitive function here is, a function of the frontal lobe. So it isn't known what causes the ventricles to dilate. Maybe they were under a state of increased pressure initially, and then that normalizes over time. But we get big ventricles. So it may arise from a failure of arachnoid granulations to absorb CSF, leading to a communicating hydrocephalus, and the ventricles push forward against those midline pathways from the paracentral lobule. All right, so NPH is frequently overdiagnosed, as I mentioned, and the problem is if you just do a head CT on every elderly individual, well, atrophy is very common, ventricles look big, and so radiologists will put in their differential, could represent normal pressure hydrocephalus frequently. Well, almost always that is actually hydrocephalus ex vacuo. In true NPH, there's little cortical atrophy. So here at this level is a normal head CT. Okay, notice that the Sylvian fissures here are pretty tight. There's no atrophy around it. We don't have enlargement of the third or the temporal horns. Here is hydrocephalus ex vacuo. Okay, here really obvious, big Sylvian fissure, big ventricular system. And here's a true hydrocephalus, where we have big ventricles but no atrophy here peripherally. And so just to give you an idea how uncommon NPH is, here's a recent study of 563 cases of dementia. Only nine were felt by neurologists to have normal pressure hydrocephalus. But when those 9 went to autopsy, 8 had Alzheimer's disease and the other had progressive supranuclear palsy, right? So even in this case series of 563 patients with dementia who went to autopsy, well, did any of them have normal pressure hydrocephalus? There were 9 that they thought had normal pressure hydrocephalus, but at autopsy, those had other features. And so, there are just several other issues. Up to 40% of patients, so a treatment for normal pressure hydrocephalus is to put a shunt in, but the shunt can get infected in up to 40% of cases. We also have really no evidence that shunting true normal pressure hydrocephalus helps for any more than 2 years. And so there's just quite a few issues with this diagnosis. In our session together here, I think on the 20th, I will talk about the CSF tap test, and I'll show you a video of a patient. So if we suspect normal pressure hydrocephalus, we bring the patient in, we do a lumbar puncture, we do a high volume lumbar puncture, and remove a lot of cerebral spinal fluid, like up to 40, 50 cc's. And then we evaluate the patient's walking after the lumbar puncture. If there's a dramatic improvement, then that might support this patient being a good candidate for putting in a shunt. One issue with the CSF tap test is anytime you do something invasive like this on a patient, there tends to be a placebo response. And so many neurologists now will do, like just where you put the lidocaine in to numb the area, we'll check the walking after that, maybe to see if there's a placebo response, and then we'll check the walking after we actually do the lumbar puncture. So I'll say more about that in our session together. And again, no proven benefit of shunting after 2 years. So I guess what I would say is if you're working at a center, you're out in practice, and you're noticing that NPH is being diagnosed right and left, that should raise some red flags, maybe get another opinion on some of those patients. All right, let me just say a little bit about a few other things. Now, this age-related cognitive decline, these are patients usually diagnosed with MCI, mild cognitive impairment, but it doesn't change over time. They remain static. They never merge into an Alzheimer's dementia. So these patients may have just some word-finding difficulty, their mental processing slows down just a little bit, but they remain static. So then we would just call it a normal age-related cognitive decline. And so this is rather sobering here, but this is just kind of what happens normally with individuals. And so just notice all functioning here from 20s to the 80s decline, speed of processing, working memory, even long-term memories. So most of you're up here in a good state. Well, here I am right here, and I'm on the downhill of most of these cognitive processing. Now notice that just word knowledge, like semantic memories, that on the other hand remains relatively stable and even improves over time. And so these sorts of memories tend to be rather stable and consistent. Okay, so age-related cognitive decline is not progressive. Patients that have depression frequently have cognitive memory complaints. And so this would be called a pseudo-dementia. And so this is just exceptionally common. And there are some key things here that can suggest to us that the memory and cognitive complaints are more depression related. So first of all, this would be usually younger individuals. It could be an older individual, but if you've got someone who's 25 complaining of memory loss, that's certainly not going to be Alzheimer's disease, right? Or even frontotemporal dementia, diffuse Lewy body. It's just too young. And so other things like depression would rise, higher on the list in terms of a differential. The onset of cognitive complaints related to depression often occur abruptly. I remember I saw a lady years ago that was very concerned about memory loss, and it began on the day of her husband's funeral. So that kind of an abrupt onset, when you see someone with Alzheimer's, it's very hard for family members to pin down exactly when it started, kind of came on gradually. Or if you have patients that tell you, on some days their memory is fantastic, they can remember everything, and then on another day they can't even remember their own name. Well, that's kind of an odd description. So that kind of dramatic fluctuation would more suggest a pseudo-dementia. In terms of cooperation, someone with Alzheimer's dementia, they're putting forth their best effort. They don't want to highlight any failures. If you ask them the date, they'll deflect and say, well, I don't worry about things at my age. Someone with a pseudo-dementia will tend to highlight their failures. And so they will, if they don't know something, they may begin to cry and emphasize, what is going wrong with them. So the interview of someone who has a pseudo-dementia frequently, when they're, sad and teary, there are a lot of personality changes that might occur along with that. And the next one here is very helpful. Remember, insight in general is lost really in most of the dementia syndromes. Classically Alzheimer's disease, where they're not aware that there's any problem. They're annoyed at family members for bringing them in. Someone with a pseudo-dementia is the one coming in telling you, I have a problem with my memory. All right, and so they're very aware and very distressed about it. Okay, so I may have mentioned this last time, but if I have a patient calling, wanting to get a sooner appointment because they're concerned about their memory, that is usually not going to be Alzheimer's disease. That may be a pseudo-dementia. And something that can be quite helpful in this situation is to do formal neurocognitive testing. This takes a long time, and what you would find in a pseudo-dementia is very inconsistent findings. And so in certain types of memory, they may do very well, and then you come back to it, they do very poorly, and then they do very well and very poorly. If you do this in someone with Alzheimer's, these neurocognitive tests, you tend to get fairly reproducible, consistent results. So these would be some of the things that would suggest we're dealing with pseudo-dementia. And then, of course, the key thing is to treat the depression. And when the depression is successfully treated, the cognitive memory complaints will improve as well. All right, so we'll stop there, and we'll see you here in a couple of weeks.